Good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Welcome back to Open Mics with Dr. Stites. A blocked artery can be sneaky because the symptoms are often very gradual. Plaque accumulates over the course of many years in our lives. Symptoms like fatigue and pain, they start kind of little quietly, but then they get worse day by day. And it can be hard to notice how poor blood flow hurts you until there's really significant pain or you get into trouble. But if you treat that blockage, you might be able to prevent a heart attack, an amputation, or worse. Today, we're meeting with a patient living with an artificial artery. We'll also meet her surgeon, who will help us understand why some patients need to go under the knife and others get minimally invasive catheter treatments. Joining today is Dr. Joed Biggs, I think I said it correctly, Gold Star, who trained at Mayo Clinic before joining us here at the health system. We also have Sheryl Craig, one of Dr. Biggs' patients. Welcome to the program. Thank you for coming and telling us about all these health problems you had. Sheryl had a major blockage in her aorta and had to have surgery last November. Of course, we're also going to have Doc Hawk here in just a bit. Dr. Biggs, let's back up. Help us explain with this cholesterol plaque that gunks up our vessels. Help us explain to us where it comes from.
Yeah, so there's a number of factors that contribute to plaque buildup in the arteries in our blood vessels in general. One of the main risk factors is smoking. Also, genetics and high cholesterol play a big role as well. And so it's important to, especially if you have a family history of arterial blockages in your family, such as heart attack or stroke, to be screened for high cholesterol or high lipid levels in your blood and consider start taking medication to prevent worsening of those blockages. As one factor, and also stopping smoking if you are smoking to prevent artery blockage buildup.
So smoking is still bad, right? That's what I'm hearing. Vaping is bad too, huh?
Yeah.
It all kind of contributes.
Unfortunately, nicotine itself is pro-inflammatory and contributes to arterial blockage formation and atherosclerosis.
All right. So Sheryl, how long have you been dealing with these kind of vascular problems?
I was about 32 years old.
Okay. So I'm going to assume that was a couple of days ago.
Yeah, I wish.
So what did it feel like when you first started having trouble?
Well, at first when I started having it, they diagnosed me with Berger's disease, and I had the blocked arteries. It blocked down in my toes to where they had to amputate.
Wait, you're sitting here and you have an amputated toes?
I do. I have 2.5.
I am sorry to hear that.
Yeah, I do.
It's a little harder to walk and do things.
No.
You're okay?
I've never had a problem.
Excellent.
Except when it got worse.
Yeah.
Then I had a problem with walking, but yeah, no, it turned into gangrene, and that's when they had to start amputating. And
yeah, gangrene's a bad thing. Just to say, that's an infection in your foot or leg or whatever part of your body that won't go away. It just slowly eats away.
Yes.
And can cause a lot of difficulty.
Yeah, it was bad. It was bad, but
so,
it's much better.
So fast forward to your meeting with Dr. Biggs. Who sent you up to Dr. Biggs, and how come?
Well, I went to my podiatrist, and he checked my pulses, and he didn't like them. So he sent me into the cardiologist, and then he sent me into Dr. Biggs to be checked after he did his scans and stuff and seen that I was blocked.
So this started at age 32, so it lasted for a couple of weeks before you saw Dr. Biggs, I guess.
Exactly.
Right. And it was initially diagnosed as Berger's disease, I think is what you're saying.
Berger's disease.
Yeah, and that unfortunately was not the right diagnosis, but instead it was something a little more sinister, I guess.
Yes.
Dr. Biggs, what was your first meeting with Sheryl like?
So when we first met, thankfully the first thing I always try to get a whole grasp of is how bad the symptoms are for them at that time. And it was very disabling in that she couldn't walk, but thankfully she didn't have any wounds currently on her feet and did not have what I call ischemic rest pain or severe pain that doesn't go away. And so we had the opportunity for looking at options to optimize her medically before considering surgical intervention, and we talked about that.
All right, so we have Sheryl's CT scan from before her surgery. Tell us what we're looking at.
Yeah, so this is a CT angiogram of the abdomen and pelvis. This is showing the aorta there in the back by the spine.
And that's that kind of white little circular object, right?
Correct, that white circular object there, right.
And it looked pretty good for a while there. It was running, you could clearly see it, and on this image, it's like it's gone. What happened?
Yeah, so it's blocked right at that level, right below the renal arteries, basically right up to the level of where the kidney arteries come off. So meaning that and it looks to be mostly thrombotic material coming up, that gray discoloration, blocking up all the way up to the level of the kidney arteries, which that will then lend to discussion about options for treatment of that. And if you play the forward video, we can see that that blockage continues down to where she had previous common iliac artery stents, which are those 2 white circles there that are blocked up.
So she's had stents already.
Yeah, they were done much earlier, and those are blocked up, and then blood flow reconstitutes at the level of the external iliac arteries and the common femoral arteries downstream.
So there's a blockage from just below the kidney arteries down to kind of where it goes into both legs. That's a pretty long blockage, right? And you think about that, that's kind of around from your umbilical cord down into your pelvis. That's a long one. And it probably puts a lot of things at risk like that.
Yeah, we worry about when you're trying to treat that kind of blockage, you worry about maintaining blood flow to the kidney arteries and how you're going to maintain that, and also reperfuse the legs at the same time.
All right, now you decided to do an aortoiliac bypass. That's a mouthful. That's kind of a bypass from one part of your body to another. You're going to describe that for us. We have a model, I think, of the graft that you actually use. Is that correct?
Correct. And if anybody is a little squeamish about surgical pictures, now's a good time to look away for a little bit here while we describe this.
And our own Vanna White is right here to help us demonstrate what this looks like.
So since she had that blockage all the way up to the kidney arteries, when we did her surgery, I actually did it with one of my senior partners, Dr. Kirk Hans. We briefly blocked above the kidney arteries and blocked the kidney arteries as well, just so that we could clean out that clot buildup and plaque buildup right up to the level of the clamp, up to the level of the kidney arteries. And then that allowed us to only have a ischemia time, or the amount of time that the blood flow is reduced to the kidneys, of, let's say, less than 10 minutes in this case. We then closed our little hole down to just below the kidney arteries, reclamped, and then that allowed us to then sew in and bring a graft in that we sewed in here. And then thankfully, when we explored her arteries in her abdomen, we found that the arteries down here, just at the low part of the abdomen, the external iliac arteries, were good to sew in graft to here and to here. So just like this is showing here, that's how it's reconstructed now.
Is that the material for the actual graft?
This is, yes. This is made of Gore-Tex, the same thing that Gore-Tex shoes are made out of, PTFE.
Wow. And it looks like almost like a blow it up if it was a balloon, but probably not. Those are probably pretty stiff, right? It's very difficult.
They do have some stretchability to the graft, not a lot, but there is some.
So now most blood vessels expand and contract. It pushes blood kind of one direction. How does that work?
Yeah, so this does still have some expansion contraction, not nearly as elastic as your native arteries, but definitely more elastic than occluded arteries.
Yeah, then you can't get any blood to that occluded artery, and then it becomes very stiff over time, right?
Yes,
so
absolutely.
That's a big challenge, I think. Okay, well, I think we have some video of this surgery. If we could take a look at that, it's pretty amazing.
Thanks.
Thanks, Vanna.
What are we seeing?
So this video is showing them, this is actually another surgeon performing the proximal anastomosis. So this should be them sewing that first part of that graft to the aorta there below the kidney arteries. And then the next part of the video will be them sewing it into the low part of the abdomen after they get through this few bites here. Sewing in what we call an end-to-side anastomosis to the external iliac arteries down there, or sewing that into the distal part of the arteries in the belly, the very downstream part.
And so tell us a little bit more about what we're seeing in here. That's a patient, but I noticed that their graft looked yellow and yours looked white.
Yeah, so there's a couple of different options for graft implantation for treatment of blockages. This I showed was a Gore-Tex graft. You can also use a Dacron graft or polyester graft, which was actually the first grafts implanted for aortic surgery, were Dacron or polyester grafts invented by Michael DeBakey. And they were showing the Dacron graft, and actually it was also soaked with some antibiotic solution, which we do sometimes when we're concerned about infection risk.
Okay. I'm having a little micro. I've got a new what am I trying to call this? A dangling ear ring for just a moment. I've got to get that figured out here. We'll get that going in just a second. So, okay, so how long, you said you clamped off the blood flow to the kidneys. That went about 10 minutes. But if it goes too long, you can cause kidney injury.
Yeah. So one of the things we think about when we're considering these surgeries is how we're going to maintain perfusion to the kidneys and how we're going to limit ischemia time or lack of blood flow to the kidneys to reduce the risk of acute kidney injury, or, for instance, the need for dialysis after a surgery like that when it involves the kidney arteries.
Okay. All right. So what about minimally invasive types of procedures? I know there's some rotor-rooter stuff going on out there, but that doesn't sound like that may have worked so well here.
Yeah, so the difficulty in this, in her anatomy, to treat this with stents, wires, catheters, balloons, would have been that there's a high risk of knocking out blood flow to the kidney arteries when you're trying to put stents up to the level of the kidney arteries. And so there have been description of procedures done for that. They become very complicated. They're less straightforward, and there's a higher risk of loss of blood flow to the kidney arteries. So that's why for this kind of blockage up to the level of the kidney arteries, I prefer open surgery for that.
Okay, so the kidney arteries sound that's pretty important, Sheryl, and I bet you wanted to keep those kidneys.
Yeah,
You lost a couple of toes, and your future as a place kicker for the NFL was limited by that, I'm thinking.
That's right. That's right.
So how's it worked? How are you feeling?
Wonderful. I'm able to walk now. I can do things
The
that I couldn't do
gangrene's
before.
gone?
Yes, yes.
So,
I don't have to use anything to support me to walk.
wow. That's life-changing event.
Yes,
then.
it is. It is.
Now, were you a smoker by chance?
I was.
And are you still smoking?
No.
Excellent. You know, I'm a lung doctor, and I can't tell you how many times a day I have to
No.
say to somebody, you know, really, smoking is not in your best interest. Yeah.
No.
Okay. Yeah, I'm still got my dangling earring. I really look good like that. Okay, so Sheryl, was it really hard to quit smoking?
Not really. Not when, I mean, as he told me, he said, Sheryl, if you don't quit smoking, I don't know if I can fix you again. And that's all it took for him to tell me that. And I'm like, I'm done.
Okay. So did you take drugs or the patch or nicotine
No, I've
gum,
had,
all that?
I use pouches.
Yeah.
And I use the lowest one. And if I want a cigarette, I pop it in my mouth, I'm good.
Okay, excellent. Now, it's been about 8 months to the surgery, so it sounds like it's made a huge difference. How long did it take you to feel that difference?
Really wasn't that bad. Within about 12 weeks, I was feeling pretty good.
That's pretty good. And is that a normal story?
Yeah, that would be expected. I mean, so the blood flow is immediately better, but there is about a 3-month recovery just from the abdominal incision. That's
Yeah.
very normal to feel out of sorts, let's say.
It's a
for
pretty
about
big
3 months
incision,
after.
and it's a pretty big deal once you get into the belly like that.
I can't
right?
wear a bikini no more. So.
Darn it. No place kicking, no bikini. What's life left to be? All right. Thank you, guys. We're going to move on now for just a moment. Send us your questions using the links on the screen to YouTube, Facebook, and the X platform. I don't know. I have a hard time saying it, not saying Twitter, Hawk. But all right, we're going to check with the COVID count with Dr. Dana Hawkinson, Medical Director for Infection Prevention Control here at the Health System. All right, Hawkeye, how are we doing?
We are doing good as far as active cases. Again, we've kind of transitioned from every day giving active case counts and total case counts. We are making that transition now. From now on, it'll probably be more like once a week, but what we can say is on Monday we knew we had 5 active cases. Today we have 4, and those are active cases, and soon, again, we will probably be transitioning to more of a just once weekly count of the active cases.
Okay, so we're down. That's great.
That's great.
And we can give once a week unless we see the numbers starting to creep up. Then we'll come back to you.
We
a little
will.
bit more
Yep,
often.
we can always pivot.
Okay, but now, Hawkeye, you look kind of swell. I'm stealing one of our studio guys' words. He said that joke. But you're a little swollen today. Have you had COVID? What happened to you?
Swole.
What
No,
happened?
this is not COVID. I think this was a good opportunity to talk about prevention. We really try to educate the public on prevention. Certainly, we've talked plenty about sunscreen, bug spray, what to do when you're outside. I was actually working out in clearing
Hawkeye,
was
you look
on
really good here. You
Saturday.
look almost as good as I do here. Go ahead. After I saw the dermatologist.
I didn't get
No
beat
shortage
up.
of
I didn't get in
dermatologists.
any fights. I was actually out working, clearing weeds on Sunday morning. I did put on my sunscreen. I put on a lot of bug spray. But unfortunately, I didn't do a couple things that maybe would have protected me from this. We think it's an allergic reaction to something out with the plants, not poison ivy, possibly poison oak or another oil or allergen that was on those weeds. So I was able to see Dr. Gear at Allergy yesterday, and she helped me a lot. Basically, I think as far as further preventive medicine and preventive measures, when you are working outside, obviously put on sunscreen and then put on your bug spray. Also, if you are working in the brush, it is important to wear long pants, long shirt, and then when you go inside, vitally important to take off those clothes, put them directly in the washer, and then go shower off, because it's those oils, those parts of those plants that just remain on the clothes, and then you can spread them on your body. So I think it's just one more thing that we can do to help the general public hopefully stay away from something like this, but it is better.
So really what you're describing is how I look every time I go fly fishing. That's brilliant, except you're minus the waders. Can you mow the grass in waders as well?
You absolutely can.
And can I ask, what is your son doing with this? Because I'm thinking your son could be, son, I can't do the grass anymore. You have to do it. I am going to react to this.
Yes. Well, he does do it. This was just more of the big weeds. I got to use some power tools.
That's okay. So that was the
I wanted
allure.
to do that.
You went ahead and endangered yourself with power tools because as infectious disease doctors, that's what you should do.
Yes.
My God. Okay.
But I'm happy to be the cannon fodder and really just, again, promoting safe practices, preventive practices to help reduce anyone else's chance of looking like this.
All right. Well, I love it. So now there's a little bit of discussion, though, about a new wave. We're seeing some rises in numbers, wastewater testing, et cetera. Is it a wavelet? Is it a wave? Talk to me a little bit about what you're thinking.
Yeah, I mean, for the last couple weeks, we've heard about that. We know hospitalizations across the nation have increased 10 to 15%, although the most up-to-date data is not on the CDC website. We've just heard the news releases about that. I think a lot of it, what we are going to do is it's going to be heterogeneous. It's going to be community to community. Just as you said, we know the wastewater has been increased detection of that. There is 3 major variants right now, the XBBs, and then there's another one called Arteries. But all of those are Omicron subvariants, and what we believe right now is that there really is no difference in symptoms nor severity of disease from this newest variant. So we will keep up to date with the latest science about that. We know that it can maybe evade the antibody responses, just as we've seen all the variants do. So that is not surprising. But again, we still have that immunity promoted by those T cells, which is very important. And as far as the new monovalent booster, just read something today. The latest information is that it should be out between September and October, maybe more of that late September, early October period. Does have some people kind of flustered because we were supposed to be able to pivot from these mRNA vaccines quite quickly, and it's been a little while now, so there is no real information on why it is taking so long. But nonetheless, we are looking more at probably near October when that monovalent booster will be available.
And this is Pfizer, not the Moderna. I think Pfizer's a little further ahead on this. Is that your sense too? All right. So, yeah, more to learn about that, about what that struggle is with mRNA vaccines and why they're not pivoting quite as well as they have in the past. And I don't know if it's more changing of the guard here, the variant more rapidly, or what it is. Maybe one of these days we'll get Greg Poland back on. I think he's coming on pretty soon. Maybe we can talk with him about that too.
Yeah.
All right. So let's see if we got some questions from our community today. Alexis, welcome back.
Good to be back. Poor Dr. Hawkinson. You were making him very uncomfortable holding that shot while you asked him follow-up questions about his allergic reaction.
You know, I was enjoying the moment, actually, because normally I'm the guy with the tight white tank top on getting made fun of, but this is my opportunity to finally take on Hawkeye.
You asked about his son. His son's going to have some social media fodder for poor Dad.
I think that's appropriate.
We have
Don't
some
embarrass our kids.
That's their job, right? Okay, here is a question from Chandler. Chandler has a great question for Dr. Biggs. He wants to know, does plaque stick to the graft?
Great question, because we can get plaque back anytime. Hey, there's my cool earpiece again. All right.
So the thing we worry about most after a surgical intervention like this with the graft implantation is actually what we call neointimal hyperplasia, which is scar tissue buildup at the hookup points of the graft. And that scar tissue buildup is accelerated by smoking. So that is one of the reasons why we discuss smoking cessation prior to her surgery, to try to reduce the risk of scar tissue buildup at the hook-in spots of the graft. You don't build up plaque per se within the graft, but you can reclot the graft if that scar tissue buildup gets so tight that it occludes or blocks the ends of the graft, so to speak, where they're hooked in.
All right, so no smoking is the answer to that, which is often the truth. If you put a group of doctors together and ask them about either lung or vascular or heart disease, the answer is don't smoke.
Yeah.
Lily has a question. Lily wants to know, again for Dr. Biggs, does the graft have an expiration date? Will it have to be replaced?
That's pretty good. This is not like the butter or something in your refrigerator, right?
No. Before you implant the graft, it has an expiration date. That's just a guarantee for sterility. Once it's implanted, it's implanted. There's no expiration date on the graft.
So the graft can last for how long? I mean, these Gore-Tex things, how long do they last?
Yeah, so reconstructions like this can last a very long time. You're talking patency without intervention of about 88% at 10 years.
Okay, so that's pretty good. So no interventions for you for a while, it sounds like, as long as you don't smoke.
Yeah, right.
Perfect, okay.
Right.
Good.
Got another one from Marlene. Marlene has a question, and this one is specific for Sheryl. Marlene wants to know, Sheryl, what was it like recovering from the surgery?
It wasn't bad. It went pretty smooth. I had to use things like walkers and things like that, and had to be, people came over to my house and nurses. But yeah, it was really smooth actually. It was easy.
And just say, I'm assuming you got up in this nice high chair by yourself.
I did.
And that
I
took
did.
a little bit of you to push off on your legs. I mean, these are not the easiest chairs to get into. So if
Right.
you got into that, I think you're in pretty good shape.
I am. I'm in great shape.
Excellent. All right.
That's a good
Alexis.
point. A lot of
Thank
us have
you.
trouble getting in and out of those chairs.
Well, I've watched you.
Jeannie Schatzhauer has a question. She wants to know, she's one of our Facebook viewers, what is the correlation between a very high cholesterol level and a cardio scan of 0? Is medication needed in this situation?
Okay, that's a complicated, layered question.
Yeah.
Right.
I would say that's a good conversation to have with your doctor, is
Yeah.
how I would end that, because that's a complicated question that would require thinking about all kinds of factors before you made a final decision there, and that's a good conversation to have with your doctor.
And a cardio scan is 0. Remember, we didn't have cardio scans for a very long
Correct.
time, and so I'm not sure. I think at the end of the day, if you have a cardio scan truly a 0, how much vascular disease do you think you can have?
Well, again,
A conversation
it's
with
a
the doctor.
loaded question.
Yeah.
But basically, the end of the story is what you're asking me is, should you be on anti-cholesterol medications for primary prevention, meaning you've not had an event in your life, you didn't have a stroke, you didn't have a heart attack, you aren't diabetic, you don't have a foot wound, you've never had an intervention on your arteries anywhere in your body.
You don't have
right?
a family history, you don't have family
Yeah, so then you're talking
hypercholesterol.
about whether or not you'd be on anti-cholesterol medications for primary prevention, and that would require looking at your family history, which would be very important, because if there's a early onset of atherosclerotic events, so heart attacks at an early age, etc., you'd strongly consider primary prevention in that situation. But again, that's a nuanced conversation, and I've had that conversation with some patients myself, but it's one that we want to have in a joint effort to decide how we're going to manage
And
that.
a lot of the cardio scans look at a lot of things like calcium, et cetera, and that may not define an unstable plaque.
Correct.
One of the challenges we have in medicine is that they're stable, kind of slow build up, and then these unstable plaques. When those unstable plaques rupture, is when pieces of the plaque breaks off, gets lodged in many times a coronary artery, and they have a heart attack. And so I think that, to your point, this is a very nuanced conversation you have with somebody who really understands your entire physiology, all the risk factors, and then you can make a decision. But there are patients who have high cholesterol, and for those very reasons are sometimes going to be put on statins or another cholesterol-lowering drug, who may not necessarily have a high score on a cardiac scan.
Correct.
So they're measuring a couple of different variables on that. Okay, Alexis, we're back to you. Now that we've confused everybody.
It's always good to get your professional explanation on this, because this
Yeah.
stuff is so complicated. Joellen has one. This would be for Doc Hawk. Joellen would like to know, or Dr. Stites, COVID booster update, please. Is the new one out?
I think you just defined that a few moments ago.
Yeah.
It's not out yet.
Yeah, and this is a very common question. Again, we know that SARS-CoV-2, COVID, has really become a disease of those most at risk. So those with older age, immune-compromising conditions, but things like heart disease, lung disease, kidney disease, diabetes. So it is very real. It still does affect and infect people quite significantly. The booster is going to be very important moving into the fall to help protect us during this other respiratory viral season, our typical respiratory viral season, but the booster right now probably will not be out until late September, early October.
Zach has a great question for Dr. Biggs. This is something, I don't know if you get this a lot from non-medical people, but Zach wants to know, do you have a personal preference between performing endovascular or open surgery? And is there a surgery that is most fun for you, if we can use the word fun?
All surgeons think surgery is fun, so we can't ask him that. But do you have a preference for an open versus a closed approach?
So one of the things I love about my job as a vascular surgeon is that I have lots of diversity in how I treat conditions. And so I enjoy both approaches for that reason, because I some days spend my day with an X-ray machine, wires and catheters, and some days I spend my day with a knife and using surgical tools, and sometimes I do both in the same surgery. So I think for me, what's really enjoyable about my job from just that standpoint, not just how I make people's lives better or help them with whatever problem they have, it's also that I have this diversity of tools that I can use and bring to the table to treat what I consider to be sometimes pretty complicated problems, and those tools can benefit patients, since I have both of those in my armamentarium.
Having all those tools is kind of fun too. I'm just saying, it's kind of like, give me a fly rod. I may have a few already in my closet, but I can still use another one. It's all good. They all have a special purpose. Alexis.
One last question. This one is from Sean. Sean wants to know, if I've had a cardio score test, am on a statin, and have low cholesterol, is there anything to worry about regarding possible artery blockage?
There's always something to worry about because nothing's perfect, Dr. Bitt.
Yeah, I agree with what you said there, that nothing is perfect, but the key is that you're trying to do all the things that you can to prevent problems in the future, and really that just comes down to choosing the best lifestyle for you to live the healthiest life that you want to live. And so that includes including aerobic exercise, some weight training into your schedule, also including medical management with the statin therapy if you have high cholesterol, or some other agent for high cholesterol, lipid-lowering therapy, and avoiding smoking. And those things will certainly increase longevity and overall health quality over the long term. Unfortunately, as in all things, nothing is 100%, but by doing everything you can do, you're definitely going to feel much better about how your life is going and your health.
I think the other answer is walk, 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 walk. The Nancy Sinatra song, walk all over you. Okay. All right, this has been a great discussion. I want to thank you, Sheryl, for coming on this and sharing your story with somebody goofy like me, but fortunately our entire audience, which will be beneficial. We want to hear some final thoughts before we go. Sheryl, you're up.
The surgery is... don't smoke. Yeah,
don't smoke.
No
there you
smoking.
go.
No smoking. Yeah, and just take care of yourself. Get exercise. It's been a great experience for me.
Makes all the difference, right? When you can get and do the things you want. Dr. Biggs.
I just want to commend Sheryl for coming on and sharing her story, and for being willing to talk about her experience, and her also commended for all of her life changes that she's made to improve her health.
Dr. Cock.
Yeah, I think we continue to promote prevention. That is one of the important things we do here at the health system. Prevention and overall health. So that is good activity, good sleep, good nutrition. Stop smoking, and as we talked about, also prevention measures outside. Wear your sunscreen, wear your bug spray, and of course understand where you're going to be at outside if you're working out in the brush and weeds. Wear long clothes, and once you get inside, take those clothes off and take a shower, and hopefully that will help again improve or really decrease your chance of having what happened to me happen to you.
I'm just hoping the time makes you look a little better. I think it will. It sounds like you already made some excellent improvement. We tease you, but we need you right here. So thank you. We're glad you're back today, man.
Always happy to help.
And then to all of our audience, just what you heard today is such a great testimony to the way you can help take care of yourself. And remember, we talk a lot about this program around faith, hope, and science. And when we see advancements like a Gore-Tex graft walking around for 10 or 20 years inside your body, allowing you to have blood flow so you don't have to have gangrenous toes, you can go out and do the things you want to do. That's due to science, right? That's amazing development of science, getting us to a better place. And you have to have a little faith and hope to get through all that. But at the end of the day, the most important ingredient in that whole story, it's you. It's you and your ability to have that faith and hope and to trust the science. Thanks again to all of our guests and to our audience. We'll see you next time.
Coming up Friday on the Morning Medical Update.
Gary Lezak spent decades watching the skies and keeping Kansas City informed. We reunite the meteorologist with the doctor who saved his life. I'm Alexis Del Cid. On the next Morning Medical Update, Gary opens up about his cancer diagnosis and the follow-up care, Friday at 8 a.m.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.